Infection, I think you know, right? There might be drainage, it might be purulent, it's probably gonna smell. Dehiscence,
Oh, when you break it apart.
right, when the wound breaks open. People at most risk for dehiscence of a wound are people who are chubby.
Or not compliant post-operatively and increase
Doing
their
too
ac-
much.
Yeah.
Right, exactly. But truly, those people, if they have good muscles and it's an abdominal wound, they don't always dehiss, even so. But people who are chubby very frequently do.
Is that for both primary and secondary?
Is that for both? No, no, this would be a primary type wound.
Yeah,
Dehiscence would be from a surgical wound.
Yeah, I dehissed, I had a, skin cancer removed.
Yeah.
Good size, and then I had a drain off of it too, and so the drain got taken off, not a wound vac, it's different.
Yeah.
And then so I had this nice little part that was healing beautifully and everything was great, and then I'm like, good, I can do more stuff. And I started vacuuming and doing things because it's on my back. No joke. Completely dehisced, got about that big, so now I have this nice, huge, round, pink scar on my back. It's like that, along with the other scars that go with it, but yeah, it's awful. And it was deep too, it's not like when you look at it, you can stick my finger down in there, probably about that deep.
Because that's how far they went down.
Yeah, exactly, yeah.
Okay, evisceration means that the wound has opened and now you got guts hanging out. Okay, evisceration means internal organs exposed. And obviously that is an emergency. You know, what we would do in that case is you'd cover them with a sterile saline-soaked gauze, you'd call the physician immediately, he would be on his way in to do surgery, because the longer that bowel is exposed, the more the risk of infection, absolutely, or perforation and infection. Okay, so first of all, we want to do some risk assessment. One of the tools we use is the Braden scale. Both of our hospitals use the Braden scale. It is covered on page 1185 in your book, table 48.3. And this was put together by a nurse who did some research on what are the contributing factors, what things are most likely to predict that this patient is going to have a pressure ulcer. And when you look at that scale, there are certain things you assess your patient for, mobility, nutrition, etc. And it comes up with a score that then is predictive of whether or not your patient is at risk. At Glens Falls, it is embedded within our electronic record. It's part of the assessment that you have to do every shift. And in that, we also make you respond to questions about what interventions are you doing to prevent the development of pressure ulcers. So, that's where you would document that you're turning the patient every 2 hours and you're using pillows and they're on a specialty mattress, or you're using maxi slides to pull them up. Those kinds of things are all listed there. So you just check the boxes to make sure you've got the right thing. So we no longer get additional reimbursement for the care of a pressure ulcer, and that's why everybody is so crazy about it. So we are really after making sure that we are preventing the occurrence, because if we don't, it's going to hurt us in the pocketbook. Okay? So here are the factors that we look at on the Braden scale. What do you think is the most important nutrient to repairing tissue?
Protein.
Protein, absolutely. So patients need to have protein. Now, for some patients, that's a catch-22. If you have a patient who has kidney failure, one of the worst things for them to eat is protein. But sometimes we have to weigh that carefully against what kind of a wound do we have to heal. Those are the very people that we have to watch very carefully so that we don't allow them to develop a pressure ulcer. because if they do, they probably are never gonna heal it. We wanna look at tissue perfusion, whatever we can do to help tissue perfusion. You know, what's their risk for infection, what is their age? And then, think about the psychosocial impact of having a wound. That cousin of mine was a very bariatric lady. She had a non-healing hernia repair, and she never got out of the house once she got the wound back on, except to go to the doctors. You know, and she had been very active, even though she was large. She had worked. She worked as an LPN. She used to go bowling. You know, she used to do things, but once that wound vac went on, she couldn't take it with her. You know, it was kind of sad. It really, really did change her life totally.
You can bring them with you, she just chose not to.
She
right?
chose not to, absolutely.
How big is it?
It's not very big. The pump itself is like this.
Carol
Hangs on the
had
edge
a
of the-
radio.
Yeah,
Oh, okay.
on the edge of, what I don't know is if they've got a battery pack, and if they do, how long it lasts. Because I have not seen people out with them. I know we keep them plugged in when they're at the hospital, so I don't know if they're like a pump that's got a
Yeah,
portable
they,
battery pack or not.
we just had a patient that had hers removed from her
Yeah.
elbow, and she has a battery pack, but like when she would go home, she'd
Yeah,
plug it in
plug it
and
in.
charge it.
Yeah,
stuff
okay.
like that.
But, you know, again, if it has an odor, that's another thing that often, you know, makes patients not wanna participate in any of their normal activities. And, you know, if you look at many of the people who have these horrible wounds have a lot of other things going on also. One of the things we need to be careful of, in addition to it having a financial impact on our organization that we're working for, it sure does have a financial impact on that patient's family also. You know, because this is gonna be a long-term care situation. You know, some of those patients who were being cared for very well at home can no longer go home because the family can't manage the wound care. You know, which means sometimes months of getting that paperwork in place. So, we are going to we're gonna look at predicting, we're gonna look at the patient's mobility, we're gonna look at their nutritional status, we're gonna look at their body fluids, and we're gonna look at their pain. What do you think about trying to get elderly patients with a little bit of dementia to drink enough? Huh? It's very hard. And for those of you that have been, how many of you have already been in a hospital to visit somebody? Ever been in a hospital? Okay, so most of you have been in a hospital. In your observation, did the patient always have something to drink close by that they could get to?
Yeah.
Okay, all right.
Yeah,
Were they able to do it by themselves?
not always.
Not always. Okay? So, one of those things I want you to remember when you get out there in your clinical practice is you have a lot of patients who can't get themselves a drink of water. How would you feel lying in that bed and want a drink of water and not be able to get to it? On the flip side of that, elderly people do not sense thirst in the same way everybody else does. They need the fluids, but they don't get thirsty. So you have to offer it to them. You have to encourage them. So with those types of patients that have a little bit of dementia, you need to offer them a drink every time you go in the room. Otherwise, they are not going to get adequate intake. You know, places like nursing homes, what they do is they have routines where they go down the hallway and everybody gets something to drink. They get a juice, they get something. You know, I know with my mom, we try to keep, she loves iced tea, she will drink gallons of it. We try to keep her cup full all the time, except last week, her make Jill crazy was, it was full moon. She'd take a drink like this, and then she'd go and she'd dump it in her hat. Jill, one day, I don't know how many times she changed her, I had quite a pile of laundry to do this weekend. Yes?
Something that I was surprised by when I was volunteering at the hospital is that I would go into the patient's room and ask if they wanted something to drink, they would say yes. And I would go into the fridge where they keep the snacks.
Yeah.
And they have soda. They have soda for
Yeah.
the patients that you can give
They
them.
do.
And I was like, shocked. Like
Yeah.
how can you, or why would you get that?
Well, if you have a patient that won't drink anything else, it's okay. It's okay.
Most of it's ginger ale.
Most of it's ginger
Well,
ale,
I've seen
right, we've
I've
got,
seen
Cola.
Kid ginger ale, but you know, just as much sugar.
Well, no, I'm not saying it's not any,
Yeah.
you know.
but you know,
works,
for
but
some of
at
those
least it's
patients who
clear.
won't eat anything, that amount of sugar isn't over the
Yeah,
top.
8 ounce.
You know, I mean, they are, we only stock little cans.
Yeah.
There's not a lot of, there's not a lot in one of those, exactly. You know, and as I say, if I had a patient who wouldn't drink anything, they probably aren't eating well either, give it to them. If that's what they'll drink, give it to them. And there is some truth to ginger settling people's stomachs. You know, that is a good thing to use if you've got a patient that's nauseous. You know, we do carry bottled water now because the water at the hospital sucks unless you happen to be on a floor that has a filter. Yes?
My grandfather passed away at 96, just this past Christmas, and he spent a lot of time in the last year at the hospital and in the nursing home. He just couldn't stay home anymore.
Right,
And when I visited him, he always had a pitcher of water,
yes,
a cup,
right,
but I always got him a straw,
right,
because
yes,
it was a lot easier for him to drink
Yes.
water through the straw than it was to hold the cup
right.
and
And
steady
try
it to his lips and.
Yep, absolutely. But as I say, we get so caught up in everything else, we forget that those patients cannot always get to their water. So we need to get to it for them.
On average, how, and I know it probably depends on their nutritional status and
Mhm.
age, but how long does it take for a pressure ulcer to develop?
It can develop very quickly.
Because my youngest sister passed away, but she was unconscious the entire
Mhm.
time. She was in the hospital and hospice.
Mhm,
And I don't remember ever seeing anybody turn her in different positions.
mhm.
So that's why I'm like, she was on her, flat on her back for 2
Yeah.
weeks.
Well, probably a big factor in that was she was healthy before she had
Yeah.
whatever caused that. Yeah, that's probably why. She was probably very healthy to begin with.
What about patients that are intubated for a long
Yes.
period of time,
They need to get turned just like everybody else.
even if they're intubated?
Absolutely.
That's a
Yeah,
solid
By
area.
virtue of the fact that the tube is in there, they've got plenty of
Yeah, it's,
length
And that
to be
tube's
able to be.
secured.
yeah, it's not as,
properly.
it's not
Yeah.
as fragile as you
No.
might think. You
No,
can move
it's-
that patient all over the place.
It not only is down there and it has a balloon holding it down there, but it also will have tape ties that go around the back of their head that holds it in place. I mean, about the only way those come out is if the patient reaches up and yanks them out.
That's
And they do that.
One puke right there.
Okay. Pressure ulcer on the heel. This is a non-stageable one. And a lot of people believe that this type of ulcer ought to be left alone. That the only measures we should do for this is to keep the heels off the bed. Does anybody have any idea why?
They won't be able to walk if you take it off, I don't know.
Well, that's not a bad thing. There's really no tissue there. You're already on the bone. And if you open that up, that exposes the bone to osteomyelitis, which means the patient might lose their foot. This kind of a stable heel ulcer is better left all by itself. That leathery stuff is doing no harm there, and it actually now is providing protection from infection. So for these, don't be surprised, don't go crazy. They probably are not going to touch it. You probably are going to use measures to make sure that the pressure isn't worse. So this heel is up off the bed or in booties or in something to protect it. Yes?
Did you start off saying that that was a non-stageable?
Yes?
Yeah.
And why?
Because it's totally covered with necrotic tissue and we can't tell how deep it goes.
Okay.
But it probably goes straight to the bone. Because there's not much there. You know, feel your heel, there's not much there. It's pretty much skin and not a lot underneath it.
So if it were open, like.
If it were open, then they would kind of be forced to do something about it. But if it's like this, they tend to leave them alone, don't touch them.
And if it's open, it's stageable, you can.
Yes.
Okay.
Yes.
So if it's left like that and it does get worse, does it go to the bone on its own?
It could,
Okay.
absolutely. You know, and patients who have those kinds of ulcers they usually get scanned to see if they can see if there's infection into the bone.
How would you treat a non-stageable?
That one, this kind of, they're probably gonna leave it alone. They're probably not gonna do anything to it.
So it will heal all by itself?
It won't heal, it'll stay just like that.
Oh, man. So they have to wear like a bootie all the time?
They might have to wear a bootie, you know, we might put socks on them and just not have